Hello, and welcome to the first Triage, Infectious Disease and Decontamination Focus Area DRC presentation of 2026. I hope everyone had a relaxing and enjoyable holiday. Today's topic is especially timely as influenza rates are rising and some hospitals may be experiencing some surges. Our presentation, Are You Ready? Strengthening Hospital Readiness for Respiratory Illness Surges, will focus on preparedness and response strategies. Before we get started, let's review our acknowledgements and disclosures. Okay, you might have seen this slide before. So just as a reminder, the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration, aka HRSA, of the United States Department of Health and Human Resources. The content presented here is that of the authors and does not necessarily represent the official views, nor is it an endorsement of HRSA, HHS, or the US government. Our planning committee, nor our presenters, have no relevant financial relationships, nor commercial support of any kind. There's information here on Joint Commission accreditation, as well as requirements to claim your continuing education credits, and more information on that will be presented at the end of the presentation. So we have our speakers here. First, we have Larry Kosiolik. I don't know why I missed. Sorry. Are you guys seeing the speaker slide?
No.
It's objectives.
Objective.
Oh, there it goes. I apologize. Okay, so for objectives, we are going to describe the key epidemiologic factors that contribute to infectious disease surges and the importance of early information sharing as well as education. Then we will move on to identify emergency room triggers and indicators that signal escalation across hospital readiness zones. And that is green, yellow, red, and then beyond. We'll explain the roles and responsibilities of leadership and clinical teams at each of the surge levels, including coordination of communication and resource allocation. We will discuss the best practices for optimizing hospital capacity and maintaining bed availability during high demand periods. Lastly, we will review strategies implemented by children's hospitals during the 2022 viral surge on the tridemic, and this was also outlined in an article published in Hospital Pediatrics. We will apply these lessons learned to future preparedness learnings and plannings. Okay, so our speakers. Our first speaker today is Dr. Larry Kosiolik. He is a pediatric infectious disease physician and the Vice President of System Preparedness, Preparation, and Response at the Ann and Robert H. Lurie Children's Hospital of Chicago. Next up will be Dr. Nicholas Glom. He is a pediatric emergency medicine physician and the Pediatric Disaster Preparedness and Response Lead for UCSF Benioff Children's Hospital. We will conclude our presentation with Dr. Danielle Zur. She is an infectious disease physician and the medical director of infection prevention at Seattle's Children's Hospital. So very glad to have them with us today. Okay, so I will turn it over to you, Dr. Larry Kosiolik.
Great. Thanks so much, Deneen. So we're going to talk to you today about how to best prepare for an infectious diseases surge. Each of us is going to give some lessons in a different context. Next slide, please. So we're going to go ahead and open up with a poll. How often do you anticipate your hospital will experience an infectious disease surge? Many times a year, once a year, every 1 to 5 years, every 6 to 10, or every 10 plus years. Okay, we'll go ahead and close this in 5 seconds. Here we go. So everyone said 5 years or less, which is interesting, and I think that is fairly accurate. Now, if the poll doesn't close for you, you can just click on the red X at the top. Next slide, please. Which is interesting. We think of like major respiratory viral epidemics, pandemics, et cetera, as occurring every 100 years, every 10 to 20 years. But in reality, those are major global events. But the impact of an event really depends on both the disease and the local regional healthcare system capacity. And in particular, when we're talking about pediatrics, the capacity might be stressed to begin with, so you can experience a surge and an interruption to operations with a relatively less epidemiologically significant event. And so when we talk about the things, whether it's endemic, meaning something like influenza that can surge, it's an endemic disease, we see it all the time, we anticipate having seasons, or epidemic, meaning it's occurring locally but much higher than we would normally anticipate, or pandemic, where it's a global increase that really does not is not confined to any specific geographic location. All of them have the potential to overwhelm your hospital system, and so you have to be prepared for them, regardless what we call it from a public health and epidemiologic standpoint. Next slide, please. If you think about a typical 45-year career in healthcare, you started medical school in the early 80s. These are just some notable national and global public health events of significance that you've experienced over the course of your career. And all of these impacted operations, and they may have not impacted pediatric care significantly, but required preparation and had an impact on hospital systems, like Ebola, for example. Zero pediatric cases in the US, not many globally, but really significantly impacted how we prepare for events in the hospital. And all of these events, despite these large ones, every year we're experiencing things like smaller local outbreaks, whether it's a salmonella outbreak from a foodborne illness, some epidemic viral illness like enterovirus, vaccine preventable diseases like measles, vector-borne diseases. All of these occur with regularity, and so these are not black swan events. These are something that we need to be prepared for. Next slide, please. So, how do we prepare for these? I want to get into the concept of surveillance, and this next poll question gets at to the types of surveillance resources you find most helpful to guide preparedness and response efforts. If you can choose one, please. Local laboratory data, local data from your health department, national data from the CDC, something else that I haven't thought of, or you don't find any of these particularly helpful. And if you do choose others and want to put any other comments in the chat, please feel free. So I think we can go ahead and close this poll. And so the vast majority consider local city, county, or state health department data as most helpful. And so what we're going to do is get into the types of surveillance data that are available to you and things that you can consider in your preparedness efforts. Next slide, please. So when doing surveillance, it's important not only to monitor the data, but to be able to communicate it. And you need to be able to use these data to anticipate both the expected and the unexpected infectious disease surge. From an expected standpoint, viral respiratory season is a perfect example. Here I provide just some examples, and these QR codes are available to you. I'm going to go through these a little bit quickly. I don't want to go in depth on any of them, but just want to give you a sense of the types of information available. But these slides will be provided to you later. CDC every year will model what the respiratory season might look like in the United States by estimating COVID, RSV, and flu activity to give you some assessment of how it will compare to prior years and how healthcare systems should be preparing. Next slide, please. Also, in advance of respiratory season, it's important to remember that the hemispheres have the opposite seasons. So in January, when we have winter in Chicago here, It is summer in the southern hemisphere. So vice versa, they're experiencing their flu season and their winter in July when we're enjoying the sunshine and not much respiratory illness. But seeing what happens in the southern hemisphere can help predict what will happen in the northern hemisphere the upcoming season. Now, it's not always perfect, but it does give you some sense, particularly if there's emergence of a new strain type. Next slide, please. Those southern hemisphere data also provide data for us to estimate what we think the effectiveness of the flu vaccine may be should the types of strains that cause disease in the northern hemisphere in the upcoming season are similar to what was causing disease in the southern hemisphere in that current season. For example, it was estimated that our flu vaccine was going to be among the most effective that we've had in years. But towards the end of the Southern Hemisphere season emerged a new strain with some genetic differences that made the actual vaccine effectiveness less than what we estimated. So there can be genetic shifts that occur that we miss with the way we do surveillance. Next slide, please. Once respiratory season starts, we can monitor activity throughout the country. The CDC, since COVID, has really enhanced their national respiratory viral disease surveillance. They now look at COVID, influenza, and RSV in aggregate and individually. And this site here allows you not only to look at national data and trends and chronology and overall burden, but also allows you to look at individual geographic areas that are most pertinent to you. Next slide, please. The Department of Health can be very, very helpful. This is, for example, at the Chicago Department of Public Health. That top image is a dashboard. This is just from our most recent, shows that what I think you're all experiencing, very high influenza activity and slightly lower RSV and COVID activity. This can give you a sense of what's going on in your neighborhood. Below the second tab are health alerts, and this is really important not only for expected threats, but the unexpected threats, where health departments will oftentimes put out health alerts to those who subscribe to give them updates on endemic and epidemic threats, not only the epidemiology, but what providers can do to prepare and respond to that. So if you have those in your area, it's important to subscribe. Next slide, please. Your internal lab may have dashboards. This is an example of a figure in a table that our lab publishes in real time. It updates every day at midnight to give you a sense of what the positivity rate is for all of the viruses and bacteria that are screened for on our respiratory pathogen panel. I anticipate many of your labs have that also, and it's important to understand how that's disseminated. Next slide, please. Having these data is the first step. The next is communicating it. And so at Lurie Children's, what we do is every other week, sometimes every 3 weeks, depending on the level of activity, we compile those data and provide some clinical operations and clinical care guidance to not only our healthcare providers, but also our patient care operation teams to help them both prepare and respond to what we're seeing in the community. Next slide, please. Somewhat related, and it's not the focus of this talk, but it's important for you to understand where you fall in terms of regional expectations for providing care to patients who may be infected with a special pathogen, something like Mpox or viral hemorrhagic fever. There's about 13 level 1 facilities in the entire country, so most of your sites are not going to be that. The CDC is now expanding into level 2 facilities that can provide care, highest level of care to patients with special pathogens. Most facilities are going to be level 3 or level 4, where they are frontline facilities, sometimes with the ability to evaluate patients for a special pathogen and observe them for a short period before transferring to a level 1 or level 2 facility. Next slide, please. So now you have all of these data. You've been monitoring, you've been subscribing, you've been sharing this information with your health providers. Now, how do you actually translate epidemiology to clinical operations? So we're going to go through some implementation strategy. Next slide, please. This poll question, when planning and implementing a response to a hazard, which items do you focus on? Staff, stuff, space, or systems and or social support or all of the above. You may be familiar with this model as usually the four S's, which refer to staff, stuff like equipment and supplies, space like where, physical space, and then systems, which are processes and things. Some implementation models add social support as a fifth S. So good. Everybody is familiar with this. They didn't get tripped up on this question at all. All of these are important and essential for planning and implementing a response. Next slide, please. So this is that model. And if you can, Deneen, if you can just apologize for the animation, go up like probably until like all the boxes show up at all 5 points. I think it'll be easier. And then I think one more potentially, or no. There we go. So these are the four S's, and I should say five is it's important to consider that fifth is social support, and you can go ahead and go forward one to activate that. Thank you. And so these are if you're let's use an example of a respiratory viral epidemic or a surge in your area. Let's start with staff. So it's important to identify which staff are going to be essential for a surge in respiratory illness. And that's, of course, going to be nurses and respiratory therapists as our most frontline staff and most essential. Certainly, we need providers to evaluate and treat those patients. We need laboratory staff to be able to run testing. Those staff need to be trained in PPE so that they can protect themselves. They should be fit tested for N95 since that's oftentimes essential for response to epidemic respiratory illness. And they should be educated in the care of respiratory illness, like how to take care of a patient with bronchiolitis, for example, how to recognize a patient who may have a need for intubation, etc. Stuff are the things that you need, the supplies, the therapies, the equipment, and those are going to be across several types, and those will be things like therapies, like Tamiflu, for example, for if you have an influenza surge. Laboratory testing, if you need to be able to identify those patients who may need those medical countermeasures. Vaccines to give either for post-exposure prophylaxis or to give as pre-exposure prophylaxis in the community during an epidemic surge. The PPE, which we mentioned, and the clinical care guidelines for those staff to follow. Your space, you should have beds across the continuum of care, and that could include telehealth for evaluating which patients need to be seen in an ambulatory or urgent care setting, the emergency department, inpatient, and ICU space. Depending on your pediatric capacity, you may see the entire continuum there or just a small portion of that. If you don't provide that critical care, you do need some planning for transferring to higher levels of care. You should identify plans for contingency surge space in case additional patients need to be triaged and cared for beyond your traditional capacity. In terms of systems, you need protocols for activating your surge plans and or your incident command system, should it require. You need plans for expanding regional capacity and capabilities, how to work with your public health officials and other hospitals in your city, region, state, etc., and how you would load balance when needed. You would need contingency care or even crisis care standards spelled out. You would need some staffing plans for how to expand staff, potentially with agency staff, if your patient care needs expand beyond your capacity. Finally, when there is a surge, staff are oftentimes working longer. They're working harder. They're working more days. Having wellness plans for them are really important to ensure that they don't burn out. That led to a significant departure from our healthcare workforce during COVID, for example. Next slide, please. So, sources of the truth in education. This is incredibly important, especially now in the age of misinformation. It's important that we curate information responsibly and we educate our key stakeholders. On the next slide here, I give some examples of what we consider to be excellent sources of truth. The Center for Disease Control and Prevention, although the CDC has come under fire by pediatricians lately because of concerns about vaccine recommendations, I still endorse wholeheartedly the CDC and their excellent professionals that perform surveillance for disease and provide guidance for many diseases. And so I already provided examples of the respiratory illness dashboards that they curate, which I consider to be outstanding, and they need to continue to be an engaged and trusted partner in public health. American Academy of Pediatrics, CIDRAP, which is the Center for Infectious Disease Research and Policy, University of Minnesota. They have taken over some resources for evidence-based vaccine information. Of course, the Pediatric Pandemic Network, we curate and provide pediatric-focused information on many infectious diseases. And of course, since many of the things that we see are not national infectious diseases problems, it's always important to consider your local city, county, or state health department and or your healthcare coalition to be able to provide that information to you. Next slide. Once you have this information, it's important to contextualize it for your audience and provide the content they need. Your audiences that are important include internal stakeholders like healthcare personnel and operations teams, local health departments. Sometimes the children's hospitals are the canary in the coal mine and seeing trends before the health department will notice because it hasn't hit adults, which is a predominant patient population. So communicating with your health department is really important. Utilizing your community healthcare providers and medical homes and urgent cares and educating them how they can contribute to a response is really important. And of course, anywhere where kids congregate, like schools, daycare programs, and groups that will engage with those community institutions, like community-based organizations, are really important. I like to communicate data, observations, and trends in a very simple way to understand. I like to communicate prevention efforts, both pharmaceutical interventions like vaccines and non-pharmaceutical interventions, like whether it's masking, hand hygiene, etc. And then also it's really important because people can get worried during a surge is oftentimes refer to an ED when it's not necessary. So advising on appropriate healthcare seeking behaviors can help balance the load between emergency departments, urgent cares, the medical home, etc. Next slide. We'll move on to our next speaker.
Great. Thanks a lot, Larry. Excellent presentation. We're now going to focus specifically on the emergency department framework. We know that winter months are associated with marked increase in emergency department visits due to respiratory illnesses. We, in the emergency department, we face heightened pressures. We see typical surges that can range from 30% increase in respiratory cases to even higher in specific seasons. So, certainly preparation for winter respiratory surges in our PEDS emergency departments. It requires really timely identification, scalable capacity management. We need to make sure we optimize our hospital bed availability and coordinate our approach in a systematic way. And so we're just going to review some examples of ways in which we can provide safe and effective care during these challenging times. We can go to the next slide, which is going to be our first poll question. So how prepared do you feel your pediatric emergency department is for ongoing or worsening respiratory surge in the next 2 to 3 months? And just select the most appropriate response. We'll give a minute for that. All right. And Donine, there we go. All right, great. So we're looking at somewhat prepared, about 57%, and about 29% feel very prepared. It is something we see on a regular basis. Great to see that. And then some great opportunities, and about 14% of the team here kind of feeling neutral on their preparedness. All right, we can go to the next slide. So our agenda, we'll just do a little situational awareness and then stick or discuss specific strategies focused on the 4 S's, also including the 5th S there that Larry had mentioned, and then share some resources. We can go to the next slide. This year, as many of you know, the CD is predicting a similar respiratory season compared to last season. We're seeing a significant increase in our flu, especially flu A cases. I know out here in California, across the country, we're amid the respiratory season as we present today. So the challenges that we face, during the season are multifactorial. We do see, our pediatric respiratory viruses drive our seasonal spikes, like I mentioned, our length of stay, return visits, and then that really provides a stress or creates a stress not only for a pediatric emergency department, but also for our community emergency departments. And then we see, with crowding during these surges, we see it's linked to delays in treatment of patients, lower care quality. For example, you sometimes see delayed administration of steroids for asthmatic patients or antibiotics for high risk infections due to the high volumes. And then we've seen increased or decreased pediatric capacity post COVID. So our community hospitals, a lot of them are shutting down their pediatric units, further stressing our pediatric hospitals. And then during the respiratory season, we also see our staff get sick. And so calling out of work and then further stressing our system. We see limitations in pediatric equipment, especially in our community hospitals. And of course, with the mental health crisis that has continued across the country, the demands and the stress that places on our emergency department continues and is really exacerbated in these high volume times. We can go ahead and next slide. From a systems perspective, the ED really can help to prevent illnesses during the season by promoting vaccination of patients. So if there are opportunities within your peds emergency department, certainly encourage vaccination for flu, for COVID-19, and then administration of RSV prophylaxis for eligible infants if that is possible. And then also providing preventative counseling for our families to help blunt the peak severity and volumes in our EDs. And then EDs can also plan to make sure that we provide equitable access, which includes providing readily available language services, certainly supporting children with medical complexity, and then coordinating with our community clinics and public health departments, including our regional pediatric surge coalitions. You can go next slide. In the ED, we can also lead the charge in terms of communications and coordination. And this really includes establishing a centralized communication hub to disseminate information. We want to make sure that we keep all of our staff members informed about changes, the surge plans, any changes to those plans, and obviously treatment protocols. And then collaborating with community partners to streamline patient referrals and transfers, certainly communicating transparency with our patients and families about surge-related changes is going to be imperative, and then providing resources to help patients and families understand these new processes, because our surge response often does result in new processes, and it's helpful just to be super transparent with those. You can go to the next slide. From a planning perspective, EDs can and should implement decompression tactics or techniques. Different examples can include expediting inpatient discharges, converting appropriate adult or PACU bed space for older pediatric patients, and then certainly using regional transfer pathways to move stable children out. We can certainly tighten our throughput by using rapid triage, basically like a see and treat type model, and then streamlining diagnostics, early discharge planning, clear admission and transfer criteria for the staff that are working, and then providing mechanisms to decompress the emergency department by utilizing inpatient surge plans and regional transfer coordination. Certainly implementing standardized clinical pathways for common respiratory presentations can also help reduce variation. It can help to speed the decision-making process for our providers, and then preserve safety under strain and stress. Certainly emphasizing time-sensitive interventions like early steroid for asthma, for example, and then build in safety checks for high-risk groups and making sure you have safe handoffs implemented in your emergency department. For those that have telehealth capabilities, certainly using telehealth or virtual ED visits, advice lines, nurse triage to manage our lower acuity respiratory illnesses, and then redirect them to their appropriate location, such as a primary care provider, if that is at all possible. And then, in addition, just consider on-site telehealth options for waiting room patients. And so that's also a method that has proven to be very effective to help reduce revisits and then emergency department dependence. We can go to the next slide. So surge monitoring has also been proven to be effective with recommendations for real-time monitoring of ED visit volumes, especially for respiratory complaints. And these can really act as an early warning proxy for impending surges. And this will also help us in anticipating volume rather than reacting to it. Note that the weeks or days with abrupt rises in patient numbers helps to anticipate these peak periods. And then certainly developing capacity level protocols that enable departments to escalate care throughout or through defined stages based on volume, bed capacity, staffing shortages, and patient acuity is helpful. There certainly are recommended real-time communications across the emergency department leadership and throughout the hospital, including the hospital incident command, our inpatient services, our and transfer centers, and then our regional partners to match patients with available pediatric capacity as best as possible. And note that there are existing challenges in implementing regional sharing of data, including information sharing or EHR integration, staffing availability, and then of course, our mental health border. In transport limitations also is a major concern and availability of our specialists, all challenges that we've been facing on a regular basis. We can go ahead to the next slide.
Nick, this is Irene. Before you move on, Mark Baker asks a question. Is your ED giving influenza vaccines to patients?
That's a great question. So interestingly, at UCSF, we used to give influenza vaccine. We have since stopped that, which is unfortunate. I have been a big proponent of giving it, but due to it was really pharmacy issues, delays in patients remaining in the emergency department for longer. But what we've done to counter that is really improved our communication with families on where they can go to get vaccinations, providing them with actual sites where they can get, they can go ahead and schedule their vaccination. But that's a wonderful question. All right. So as part of surge monitoring, it's also important to identify and track surge triggers in the emergency department. Examples of different triggers for surge within the ED can include, your ED census, your boarding hours, or left without being seen rate, and pediatric ICU or ward or inpatient occupancy. It would be helpful really to develop the capacity of tracking these triggers and alerting and use them to alert ED teams when thresholds are surpassed. Another possibility for pediatric emergency departments are to use or modify existing overcrowding scores, such as the NEDOX, which is the National ED Overcrowding Score, and PDOX, which is the Pediatric Emergency Department Overcrowding Score. I do consider modifying the NEDOX, as NEDOX was really developed for adult emergency departments, and there are metrics included in that calculation that are not as applicable to pediatric emergency departments, like the number of ventilated patients in the emergency department. And then with PDOX, there's not a significant amount of evidence behind this scoring system. It really only measures the total patients registered and the number in the waiting room. So another option is to basically develop your own dashboard with specific triggers for escalating levels of surge response, and you can study NEDOCs and PDOCs to see how applicable it is to your setting. So, but whatever you use, it's important to activate and then educate your team about the clear surge plan, and this really includes defining and using tiered surge levels with objective triggers, and then tying them to specific options for specific actions about how to ameliorate whatever the challenging situation is. And when there is a sustained surge, certainly consider standing up incident command. We're talking days, you're heading into weeks of this sustained surge. Consider setting up incident command to help streamline the huddle structure for pediatrics. So decisions about beds, staffing, transfers happens more quickly and consistently. We can go to the next slide. This is an example of the Epic patient real-time tracking dashboard. This is one of the Epic real-time tracking dashboards. This is one that we had here at UCSF. We're actually in the process of revising and have almost completed our patient capacity dashboard with the before mentioned triggers all displayed on the dashboard. And then the idea is that the triggering of a metric will result in an ED huddle to assess possible interventions available on the surge plan. Then go to the next slide. And this is an example of one of our emergency department surge plans. I'm not going to go into too detail about this, but you'll see at the top we have different triggers for each of the different surge levels. And then below we have, you can only see systems here, but we have a list of different reaction opportunities to when we meet a different surge level. So we have all the 4S's with all the different options in which the emergency department can respond. And again, we didn't want to be too prescriptive because there's so many different variables that can cause a surge. And so we wanted to provide some flexibility so the team can kind of pick and choose what they feel might work. And then, of course, we are studying this as we move forward. So we make sure that, we know that we're actually helping to improve our surge levels. You can go to the next slide. Our strategies for space include certainly pre-planning strategies to expand our capacity, and that includes optimizing and maintaining bed capacity. We want to expand our surge beds. If you can create additional bed space within the emergency department or use alternative care spaces for your emergency department, certainly would help. Certainly activating internal surge plans and your regulatory waivers for temporary pediatric capacity expansion. And then prioritizing inpatient bed assignments for emergency admissions and consider scheduling changes to elective procedures during really high demand, like sustained surge periods. And that would be done in coordination with our HICS team. And then you want to use urgent care expansions and outpatient resources to divert non-emergent cases, and then monitor house-wide, just constant monitoring of your bed census and throughput triggers. Let me go to the next slide. For our staffing strategies, certainly want to plan for a tiered staffing model with surge schedules, and that really is going to include developing strategies to increase staffing quickly during a surge and provide just-in-time training and caring for children or cross-training of any non-pediatric staff. Certainly planning for staffing shortages due to illnesses and caregiving. Just go ahead and expect that that's going to happen. And then consider implementing team staffing models when necessary to enhance patient ratios. You want to proactively enhance staffing plans to meet future demands, and then support hospital flow to prevent patient boarding. And then, as Larry had mentioned, incredibly important, address the staff well-being and resilience over weeks, not days. You want to provide staff rest periods, psychological support, clear communication, just to make sure that your staff is also being taken care of. You go to the next slide. The strategies for supplies, considerations include, establishing supply chain contact, addressing this on, ongoing shortages, making sure you're staying ahead of the game when it comes to your supplies, collaborating with pharmacy to manage medication needs, and then any mitigation strategies for shortages that you might encounter, and certainly collaborating with the laboratory to establish effective systems for supply monitoring, planning and procurement and administration of routine childhood vaccinations, again, if you are able to in your emergency department. We can go ahead to the next slide. Next poll question. So how did you apply lessons learned from prior respiratory surges, from after action reports or other general reviews? Go ahead and select all that apply. All right, and go ahead and end the poll. So kind of looks like all of them. Yeah, training exercises, supply chain improvements, space reconfiguration, policy and procedure changes. Yeah, across the board, incredibly important. All right, we can go to the next slide. Again, other practical recommendations, just continuous improvement projects like QI projects, really to help refine the processes in your surge plan. Certainly, as mentioned, expanding your outpatient urgent care capacity, and then community hospital outreach, really helping to provide our community providers with the tools and how they can care for children during these respiratory surges. And the next slide has a number of our different references that are available to you either through the RAPM site, other sites, or the PEDS Pandemic Network Resource Central. And now we have Dr. Danielle Zare is going to talk about a case study from the 2022 viral respiratory surge. Dr. Zare, take it away.
Thank you, Nick. Yes, so I will be talking about results from a survey study that we conducted with the 10 PPN hub sites. The goal of this study was to describe the strategies that the 10 sites use to maintain capacity during the 2022 viral surge. The QR code there and the link will take you to the paper that resulted from this. Next slide. So we had three categories of questions, three of the S's, system strategies, space strategies, and staffing strategies. And we'll start off here with system strategies, but I want to just orient you to the graphic that's going to appear on the next few slides. And that's really showing you the percent of PPN hub sites reporting that they practiced a certain strategy. So the X axis is the percent of PPN hub sites reporting yes, and the strategies are on the left there. And you can see the bars are measuring the number of sites, and the green top bars are what's happening in the ED setting, and the bottom orange bars are what's happening in the inpatient setting. And I'll just highlight the top results in each of these areas. So system strategies that were used by most sites in the ED setting were to provide support for community clinics and hospitals to try to keep kids in the community rather than sending them to the ED, to provide messaging to families about appropriate ED utilization, and then to take steps to increase sort of strategies to support families in the waiting room. So they were waiting there for such a long time. So to make it a little bit easier on them. And then on the inpatient side, again, to provide support to community hospitals to try to keep kids in the community rather than needing to send them for admission to the Children's Hospital, to provide higher levels of care on non-ICU inpatient units to try to keep kids out of the ICU, to practice more direct admissions to reduce flow through the ED, and to participate in regional coordination to better distribute admissions over the community. So now to dive into the next slide, a little bit more into the specifics around the support provided to community clinics and hospitals. You can see here that 9 out of the 10 hub sites provided educational materials on care of common pediatric illnesses, both with regards to the ED setting as well as the inpatient setting, to try to, again, keep those kids in the community. Next slide. So now in terms of spaces, you can see here there's a lot more variability across the 10 sites. There really wasn't the same sort of alignment that we saw in the system level strategies. And so all different kinds of spaces were used, clinic spaces, after hours, waiting rooms, non-clinical spaces, et cetera. And this happened in the ED and then also on the inpatient side. I guess the most common site that was used on the inpatient side was use of the PACU for inpatient space, and then also use of inpatient treatment rooms. Next slide. And then for staffing, we do see a little bit more alignment here. For the ED, there was an increased use of travel RNs, flexing nurses from other sites in the hospital to the ED, and then also pulling RN leadership into providing direct patient care. And similarly, on the inpatient side, we saw an increased utilization of traveling RNs, and then again, RN leaders being pulled in to provide frontline care. Next slide. And then these are the strategies that were used to manage the surgical demand. 9 out of the 10 sites boarded or admitted patients to the PACU after their surgery if they required hospitalization, and 8 out of the 10 sites postponed elective or non-urgent cases. And no children's hospital wants to do this, obviously. So it's kind of telling, I think, that 8 out of the 10 were needing to do that. Next slide. So we definitely need to acknowledge our limitations. The results are highly descriptive. We didn't evaluate the effectiveness of the strategies that were utilized, just that people use them. And the hospitals represented in this report are large academic children's hospitals whose challenges may very well be different from those of smaller community hospitals. Next slide. So now we want to hear from you. Which mitigation strategies are most effective in your experience? And you can choose up to 3. Maybe none of them. Great. Okay. It looks like people were feeling like there are a number of strategies that were useful, implementing rapid discharge and throughput strategies, workflow and triage changes like standardized pathways for treating various entities, and then adding and repurposing space. All right. So we can move on. And if people are willing to come off mute, we'd love to hear from you. What other ideas have you used or anything else that you'd like the group to know about? Or you can put it in the chat.
Hey Danielle, this is Johnny. I found early testing, so running tests from the triage, just even point of care flu testing, just so you have the answers faster, has really expedited our throughput. And not to say that if you have the flu, that's the only thing you have, but it does certainly help if somebody's coming in with, we'll call it influenza-like illnesses, that you can sort of tell the parents this is what you have, and determine if they're appropriate for antivirals and sort of get them on their way.
Great, thanks for that. All right, well, if people don't have other ideas they want to put on the table, I think we can move ahead.
Good afternoon, everybody. Hi, my name is Irene Navis, and I am one of your facilitators for today. And we just wanted to get into some discussion. If you have additional questions or comments, we had one question in the chat already. If you have other questions that you'd like to put in the chat, I want to call your attention to a number of resources that have also been added to the chat. And also, if you wanted to introduce yourself and list what facility you're from, we'd love to have that information in the chat as well. So would anybody like to start with an additional question or comment for any of our panelists, or just in general?
I'll go. This is Johnny again. Sort of to piggyback off my comment for Danielle and Larry and Nick from the PEM side, what do you find is the role for point of care testing, viral respiratory panels, and then what if this is sort of a secondary question, the role for antivirals in this flu season, having recently purchased Sofluza, it is very expensive. And then the role of Tamiflu, which has sort of, I would say, mixed data.
Yeah, I'll start. I mean, I think this is a challenge. I think we need to balance the need to know with clinical actionability, cost, clinical throughput, et cetera, right? Like if you're doing testing on everybody that doesn't need it, the lab costs go up. You need more lab techs to do it. You need more instruments. It slows down the results from the patients that need it. And so what we advise, like we have full all year round, we have the broad respiratory pathogen panel with 20 different targets. And so the cost of that is based on the number of targets. And then we have single target COVID testing. We don't have a flu COVID PCR. We only do that during the winter. And so we advise on scenarios where it may be helpful, like patients admitted to the ICU, patients admitted to the hospital where the result may impact your exploration of other diagnoses like Kawasaki disease or it may result in you not giving antibiotics, for example, uh, or may result in you giving Tamiflu or some other antiviral. I tend to recommend Tamiflu according to the AAP recommendations, which is if you're hospitalized for influenza, you should get an antiviral. If you're not hospitalized for influenza, it's based on duration of symptoms and risk factors and whatnot. I think the challenge is, as you point out, is that the longer you wait, the less effective it is, and depending on the population, may not have a substantial impact. Like shortening a day of symptoms is different than potentially preventing a hospitalization. So kind of you have to put all of that together. A lot of kids don't tolerate it. I can tell you, both my kids had influenza last week. One kid threw up on the first dose. It's the second time that happened. Refused to take any second doses. The other took it and tolerated it. And it's hard to predict which kids are going to have the GI intolerance and which aren't. When you're looking at like the inhaled zanamivir and the single day dosing drugs, for example, they become quite pricey, several $100s. And so it does impact the ability and equitability of being able to obtain it. But in general, the short story is if it's going to impact your clinical management, I still think it's a helpful test. If you're just doing it just from an academic standpoint to know what's going on, then I think it's less helpful.
I agree with Larry, and I'll add that our third-party payers aren't paying for the 22 target panels now, and so we're really limiting their utilization to those situations where it's really necessary. So severely immunocompromised patient or critically ill patient or what have you, and we're really taking them out of the urgent care and ED setting for patients who are being discharged, although we did need to stand up other ways to test for pertussis and mycoplasma. So that's the complicating factor there. And I totally agree using the short panel PCR to identify flu is really helpful during the time of the year where you're seeing it, but it's not everyone with flu. Can be super helpful to have those results. And oftentimes we'll get to a point in the season where the rate of influenza is so high on those presenting with respiratory that we can just skip right to the treatment. At least that's an option for people to use.
Yeah, completely agree with what Larry and Danielle said. Very similar situation here at UCSF. Practically what I do in the emergency department with a lot of patients or families is just shared decision making. So sharing everything that was just discussed, the side effects, the potential for decreasing symptoms and duration of the illness if we catch it early on in symptom onset. But also sharing, the side effects, as Larry had mentioned, the cost, and let families kind of come to their own conclusion. I definitely don't push it. I don't go to it right away. The only time we really do it on a fairly regular basis are complex medical kids coming in febrile that are being admitted to the hospital. So completely agree with everything that was said, but shared decision making is, I think more times than not, the parents have opted not for testing. But that's just anecdotal in my experience, but that's the way I approach it.
Anybody have any other questions for the panel?
I have a quick question. Nick, I know you mentioned steroids and antibiotics kind of being something that may slow down throughput in the EDs. Would you say that the procurement and administration of medication is the biggest bottleneck that you see in the ED, or what is the biggest bottleneck that you see that really slows down that throughput for the ED?
Well, I think and that was really tied to having, like within your electronic medical records, having protocols. So for asthma, you have your set protocol. It's just basically a checklist. Based on the severity of the patient's presentation, making sure or it just makes it much easier to order the medications. And then ensuring, in collaboration with pharmacy when there are time sensitive medications, like getting steroids in as soon as possible, certainly less than an hour. Same thing with antibiotics, kids coming in sepsis or hematology oncology kids that need antibiotics, obviously with fever. Coordination with pharmacy to prioritize those. So having those protocols set and established pre-respiratory season really helps in regards to efficiency and making sure that we get timely administration. So the bottleneck would really be if you didn't have those protocols and somebody initiates treatment for asthma, yet they forgot to order the Decadron because it wasn't right in front of them in the order set, things like that. So having things more protocolized so that much easier to order, you're not forgetting things, making sure that kids are getting the treatment that they need. But also, and part of that protocol, it's a coordination with the pharmacist, with the nurses, making sure that everyone's on board, understanding the timeliness and the importance of that, especially during surges. Yeah. Great question.
I would add, like, thoughtfully using your Pyxis can help with that too, in terms of like what medicines are immediately available in the ED. And what's hard, the Pyxis has a limited amount you can store, right? And so we've had to make changes where, like, for example, when the febrile neutropenia guidelines changed, in terms of the type of antibiotic that should be given and the time in which it should be given, we found that the bottleneck was from pharmacist to the ER. And modifying the Pyxis like cut down that time. Same thing with the sepsis guidelines. If you're in a combined pediatric and adult ED, it may make it challenging because the adult medications and doses and formulations and things based on volumes may limit even further what you have available for kids. But in a pediatric ED, it makes it easier to target on your pediatric only population.
Thank you. We have one from Mark Baker. We see delays related to consultants responding and often requesting additional workup in the ED prior to accepting admissions. And any comment back to that? Or Mark, did you want to expand on that further?
No, I know some shops use kind of mandated timeliness for consultants. We haven't done that, but I know that it's been helpful in other places.
Yeah, it's such a great question. We've actually implemented that mandatory response time and kind of an escalation pathway if we use Volt communication system within our hospital, and you have your first call for your consultant. You put in consultant order in Epic that automatically notifies them. In addition, you can send them a message on Volt if they're not responding within a certain period of time. You escalate to the next level, which would be the attending. And then certainly, as part of, kind of similar to protocols, I think including your subspecialty services, your consultant services, in the planning for surge is incredibly important so that, if they do, let's say it's an endocrine patient and they need additional thyroid testing, other testing, but it's not going to impact whether or not the patient's being admitted. Certainly, having discussion with the team, at that point in time, if they're requesting additional testing I agree, let's get these tests, but we can do that on an inpatient basis. And the inpatient team can go ahead and solve that problem. But I think to prevent having those discussions before, I think including or socializing the consultants to the surge plan, because many consultants just don't understand the impact that is, the emergency department is experiencing and the number of patients in the waiting room and how we really need to be quick with our dispositions. I think, including them in the surge planning process, I think can help with that. That's a great question. Yeah.
Thank you. And thank you, Mark, for bringing that up. Janine, I think you had another issue to bring up.
Nope, I think it was answered. Thank you, Irene.
Oh, great. Okay. I just wanted to bring up one quick thing to see if there's any reaction from the panel or from anybody in the audience. One of the things we learned at my hospital at UMC in Southern Nevada during the pandemic, as well as the triple-demic, is the importance of C-suite engagement and C-suite buy-in for a lot of the protocols and changes and supply chain issues and responsiveness that needed to happen from that level. Does anybody have any comments about that or a success story they want to share about C-suite engagement and how that changed as a result of the pandemic and triple-demic?
Yeah, I think it's a great question. And you're asking, I'm sorry, should I give a chance for our teams to respond first? Sorry.
Go
No,
ahead,
you
Nick.
go ahead.
Yeah, you start.
Sorry. I'm just super passionate about this. Sorry. With our surge plans, it was incredibly important that we did not develop it in silo. What we've done, and we call it our capacity plan, which is essentially our surge plan. So our inpatient units are also involved. They create their own a similar format, same color system for the levels of surge, but they create their own surge plan. And C-suite is heavily involved in that coordinated process to make sure that there's integration and an understanding of who is doing what in the event of a surge. So cannot emphasize enough the importance of engagement with C-suite, your nursing leadership, your medical director leadership within the hospital, and the ancillary services, as I mentioned, so they understand exactly what expectations are, so they're not kind of going through an educational process in the middle of a surge. Great question.
We'll go to Larry for a quick wrap up, and then
I think
Laura has some final.
some other things that have helped for us, like both I think having those relationships with your C-suite should be constant and sustained and not only in a crisis. And so we have what's called a health delivery council here where every Monday, led by our chief operations officer, there's leaders from all of these departments and teams involved in clinical operations, and they do like a round robin report out. And so, and they're giving like early warning signs of issues, and you're starting to talk through very briefly solutions. And so you learn to trust each other, you learn to have some general approaches. And then one thing that's helped us with incident command to avoid your incident command team from becoming 100 people and trying to solve every problem within your incident command meeting, we've created operational teams within incident command. So it's not the chief operating officer solving the issue. We create a subgroup that is responsible for addressing the laboratory supply and throughput constraints of this viral surge. They have representation from incident command, but also like the frontline people that really understand like the nuance of addressing that issue. Then they develop a solution from the operational standpoint, and that feeds into incident command, and then the C-suite is the one making decisions based on an informed and well represented specific response to a problem. And that's helped a lot with creating a clear line of communication and putting the responsibility for solving some of the issues in the hands of the people that are closest to the problem.
Thank you so much, Larry. And we're going to, in the interest of time, because we have to move on to another session after this, some of us do. Laura, would you like to take over from here?
Absolutely. Happy New Year, everyone. Thank you to all of our speakers and to all of you for attending. This is clearly a critical topic, and I hope the information is useful to you. I put the DNC email so that you can reach Julie or I with follow-up questions for speakers or just questions about the DRC in general. Next slide, please. And the session evaluation link is in the chat as well, because we've got limited time. So this is a complicated slide, and it's simply meant to remind you that this phase of the DRC is where we ask teams to focus on planning and convening a drill number 1, and then a follow-up drill number 2. The materials are organized, the drill materials are organized by the focus area on the tabletop exercises and drills webpage link. And I'll hopefully have time to put that into the chat, but if not, you'll find it on the DRC homepage as well. So we want to make sure that everybody understands the importance of choosing one or more focus area specific process measures to test out using both drill 1 and drill 2. You can find that information in the drill materials as well as on the focus area webpage. So as you complete your drill, you finish your after action report and your improvement plan, noting either the times or the percentages from the process measure. And then you'll receive an email later this week where we're going to ask you to identify the point of contact who's most appropriate to complete the drill data outcome survey. So we only need 1 per hospital or 1 per team. And if you've chosen more than 1 focus area and are going to do a drill for each of those, you will be doing 2 drill outcome surveys. Of course, you can ask for questions at any time. Next slide, please. So the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals, otherwise known as the PDPAC, is now complete. Hospitals that submitted this survey have an opportunity to see a dashboard of their results compared to all results through the PPN portal, the PDPAC section. Those identified as the point of contact for the survey within your hospital, the folks that submitted the assessment will receive an email this week to give them information about how to access the PDPAC portal. There's also office hours that will be sharing details with you about that. You can ask questions of the staff, or you can join office hours if you're having questions about accessing the portal or your your dashboard. Next slide, please. Oops, sorry. So this is just a reminder that you can find all of the details for the upcoming sessions with registration links, as well as completed sessions, recording and slides, and Padlet for reunification on the DRC Collaborative Sessions webpage. Next slide. Upcoming sessions. The February 3rd session is a collaborative session, and it's pretty important. You'll hear Kate Remick and Adam Becker talk about the PDPAC results for DRC teams, and there is a speaker who's going to come and talk about maintaining C-suite and other leadership support for pediatric preparedness efforts in an ongoing manner. We've heard from several of you that while during the Disaster Networking Collaborative, that was a focus and people were able to get good support, that it might be waning due to other competing priorities. So we're going to bring it up again. And then we're hoping to have a hospital present on their drill as well. And then the March and April sessions will be focus area sessions, and then we will complete the whole collaborative by having a May and June session where we will have everyone invited to those. Next slide, please. These are just a couple of PPN resources that we were asked by the education domain to share with you as follow-up to our fireside chat on these topics in November of 2025. Next slide, please. A reminder, probably your third or fourth, that the next NPRP is coming up, opens in March, and we hope that every single hospital, this is community hospitals, children's hospitals, etc., will again participate in this important assessment. Next slide. This is how you claim your CE. You can see that little code there that you can text to and the number, or you can go to the link and enter the session code. And if we are not allowing you time to do that, then just email me and I will give you those codes. Next slide. Please do complete the session evaluation. It's right up there, the last link that I put in the chat. Are there any final comments that any of the hosts want to say? Thank you, everyone. We really appreciate your participation and your support. All right, I'll say thank you. And those of you that want to join the next series of focus area sessions, we will see you there. Goodbye.